So in the interest of time, as Billy says, I don't think we have to dive too much into the details here. This was use of positive oral contrast agents in abdominopelvic computed tomography for blunt abdominal trauma, meta-analysis and systematic review. As it talks about, this is a meta-analysis and systematic review, and it's basically they went through, they kind of looked at the papers, and they said it appears that oral contrast does not add anything to the diagnostic accuracy of abdominal pelvic CT scanning. I thought it was very odd that not only did they look at our usual contrast agents, but this is a European article, and maybe they do things quite differently there, but they also found, I think, 17 articles that looked at the use of neutral or negative contrast. So I can't remember the last time I ordered a paraffin contrast CT scan, but apparently there's
don't have to.
There's literature for collagen, milk, and corn oil emulsion, but I think you can lump it all together and say there does not appear to be any benefit for adding oral contrast to CT scans.
So blunt abdominal trauma is also, if you think, now many blunt abdominal trauma patients don't have that much wrong with them, and their workup's often sort of an exercise in futility. But if you picture a sick blunt abdominal trauma blunt abdominal patient who's got multiple things going on, the last thing I want to do is take a patient who's supine in a C-collar, maybe head injured, possibly vomiting, and put a quart of contrast down their NG tube. One of the things this paper didn't find, but some of the other papers that are in this meta-analysis did find, is that it's harmful. You have aspiration issues, you have other problems. And these patients are potentially pre-op if they're found at their scanner to have, a grade 3 liver. They might be going to the OR, or a blown spleen and things like that. So I love it how we're going to take an NPO multi-system trauma patient and load them up with oral contrast. I don't think so. So I don't like this, not only for the fact that it doesn't improve my diagnostic yield, but primarily because I think it's dangerous.
So numbers 16 through 18 are 3 different permutations of you don't need contrast for CT, and they involve trauma, they involve non-trauma, they involve IV contrast, oral contrast, etc. Instead of going through all the details of all the articles, in the interest of the time, maybe one of my colleagues can summarize when are the only times that contrast is useful.
Go.
Well, oral contrast, honestly, I think the only time you really need oral contrast, well, there's 2. One is bariatric surgery patients, and I want to emphasize that because somebody who's had a Roux-en-Y surgery for bariatric surgery has a blind loop that you will never see unless there's contrast. And that's a loop that actually can cause a huge amount of problem for these patients, and actually the loop can twist, the loop can die, get ischemic, it's a big problem. And
There's an internal hernia it gets that tends to show up on board exams called a Peterson hernia, which is a big surgical emergency.
Unless there's oral contrast. So if you have a bariatric surgery patient with belly pain, that is someone that you will want to use oral contrast. And it's bariatric open surgery. This isn't the ring. This is actually the true diversion kind of procedure. So that's one instance. The other instance that is argued by our, for oral contrast, is argued by our surgical colleagues, I think, is obstruction. They want to see the cutoff point. They want to see where the obstruction actually is. I'm not sure that is a strong enough argument for me to use it. We have some pushback. We have a lot of sort of debate with our surgeons about that where I work. But that's another area where you might hear it bandied about. So that's
the transition point
is
better seen. Mm-hmm. But I also think that nowadays there's a fair number of papers saying that the transition point is pretty accurately determined without it. That's not so subtle that you have to have it. And I would add one more place where you want oral contrast is where you're looking for fistulous tracts in a Crohn's patient or someone who's had multiple intra-abdominal abscesses, things like that, where you're looking for, is there a fistulous tract? Is there evidence of perf? And other than those types of indications, and I'm completely in agreement with Di on the others, we don't use oral contrast, and it took a long time at an academic medical center of, keep pushing papers at them and having ongoing discussions to finally get our academic unit to yield. That does not mean your local radiology group is going to yield.
What about diverticulitis within patients? Is that something that's
Our radiologists have yielded that we don't need it for that. Mm-mm. I mean, I think of diverticulitis as sort of like, if you will, allow it, left-sided appendicitis. So if I don't need it for appy, I don't need it for tics.
One might also ask how often do you actually need a CT for diverticulitis, as for appendicitis? We get into the habit of doing these tests because we do them, but in fact, maybe a better question than do you need contrast is do you need a CT?
So the American College of Colorectal Surgeons, imagine that meeting. Ooh. Ooh. Anyway, they say that diverticulitis is primarily a clinical diagnosis, and there's this thing called the Hinchy classification, if you want to look it up. But Hinchy 1 and 2 are really clinical diagnoses.
So we are going to try to go faster. So if you want to tell us quickly about IV contrast.
Go for it.
No, go ahead. You have number 17, or Billy, you guys talk about, I've heard you talk about this a lot.
There's not a lot of need for IV contrast unless someone is basically super skinny. Okay, that's one potential area where you might need some IV contrast. But overall, we don't.
The one place where we go for it is when you're
Vascular.
actually doing a CTA. You think they
Vascular,
have,
right.
you think they have ischemic, one of the three variants of ischemic bowel. So there's the embolic ischemic bowel, the true sort of bowel angina, and then the outflow obstructive portal hypertensive ischemic bowel. But ischemic bowel is, you really want to see vessels, and because you're also contemplating a therapeutic action based on what those vessels show. That's about it.
Right. So for vascular reasons is when you have that special case is the only place where I think that IV contrast is used. Think back just what we just heard, that mostly the bigger question is, did you really need a CT? If you need a CT, or any study, but if you need a CT, in emergency medicine, it's rare that we need any type of contrast. There are a couple of exceptions, but it's really, really rare. And this is something that 2 generations ago, radiologists wouldn't consider. Now it's starting to be considered. In 10 years, I think this will be a sort of a moot point because they'll be doing it. They'll have learned how to do it. Billy, I think it's just worth stressing what Billy said about you have to figure out how to make it work in your group because they're going to be resistant. This is how they've always done it. When they get new members in their group, it'll be different. But for now, you're going to have to push them to get them to stop doing it. And we don't have to tell you all the reasons why it's bad. Forget about medical complications. It just takes it's a waste of an enormous amount of time. And then there's all those questions about do you have to get creatinines and all that other crap. It's just ridiculous. And I'll just also add that I love the concept of NPO. These are patients who are NPO because it's really dangerous for them to take a sip of water. But 4 liters is just fine.
I love it when you come in for, it's a Saturday morning, you're coming in for your shift, and the evidence of complete intellectual surrender of your colleague. And don't trust me, nights are hard. I know it. They hurt me now more than they ever have. But you come in and you get passed on 5 people waiting for abdomen and pelvis CTs. It's like, oh.
How about number 19?
19 is a great little paper. It's not great for its methods, it's not great for anything, but it's great to remind us. The title sort of, where it's going. It says routine nasogastric decompression in small bowel. Is it really necessary? Question. So the answer is no. So it's not really much of a study. It's a Yale paper, 290 patients with small bowel obstructions. For some reason, they didn't include hernias. I'm not really clear on why they did that, but all the patients had nausea and vomiting, and they note in no specific, really randomized fashion, that 19% of these patients never got an NG tube. Many didn't get surgery, and 2/3 were non-op managed. Of the NG tubes that were placed, they found that a lot of them had really minimal drainage. So the idea that it really unloaded these patients and they felt better because of that was challengeable if you just measured the drainage. It was under 100 cc's in a lot of them. And then they say, and by the way, when we looked at the ones who did get NG tubes, they had longer lengths of stay, longer time to resolution, higher complication rates. They more often were sent to rehab. Wow, that's not fair. It wasn't a randomized trial. Let me just guess that those patients were the sicker patients. That's why they got the NG tube. They were trying to get to non-op management. They couldn't. They had delayed surgery, some of them, et cetera, et cetera, et cetera. So I don't think it's fair to say that the NG tube causes longer length of stay and resolution time and things like that. But I think it's very clear that in the run-of-the-mill, post-surgical, small bowel obstruction where it's probably a band, where it's pretty likely that they're going to be non-op managed and the patient hasn't had a huge emesis recently, that maybe you could forego the NG tube. And I'll just add this, because we've done a bunch of papers where we ask patients, what is the most obnoxious thing your doctor does? And we do a number of obnoxious things, but at the top of the list is an ABG and an NG. And you all know what it's like when you're putting that NG tube down, you send the student in and the patient's like, not the left side, not the right, neither side, I don't want it. They're shaking it off. They don't like this procedure, so if we can avoid it with some common sense, and I think clinical common, there's not a lot of thought here, this is just clinical common sense. If they're looking pretty good and you're going for imaging and they're not actively puking their brains out, you can control it with 4-azopharan, I don't think you need to add insult to injury by jamming plastic up their nose.
All right, abstract 20. The NOTA study, non-operative treatment for acute appendicitis, prospective study. So it's a European study, and obviously it's European because only 17% of patients got a CT scan. Isn't that interesting that we can hardly do an appendicitis without a CT? Only 17% did here, 73% were scanned using ultrasound, and of that, about 3/4 had some positive findings on ultrasound, but largely they make their diagnosis of appendicitis on clinical grounds. And then they essentially just report, this is our experience with trying to do non-operative management. This was an observational prospective study. They had a small initial first week failure rate of about 12%. And so those patients in the first week when they failed, they all went to the operating room. But then over the subsequent 2 years, they only had another, I think, 24 patients fail. And even on the second go-round, the majority of those, I think 18 of them, were treated medically. So they had an overall success rate, I think it was 83%. And to me, this opens up just a very interesting dialogue when we're dealing with appendicitis or even possible appendicitis. And that's one of the criticisms of this article. Well, they didn't all get the gold standard, which is presumably, it's really surgical examination of the appendix, or the anatomical microscopic examination is probably the best gold standard. So we don't really know that all these patients had appendicitis, and in fact, they report at least a couple of them had tubo-ovarian abscesses. But I think it opens up the whole potential that we can, one, treat these patients medically, and two, we potentially don't have to hunt this diagnosis down to the very last breath of the diagnosis. And those patients right now that have a little bit of right lower quadrant pain and tenderness, and we're thinking maybe it's an appy, we currently feel very obliged to confirm that supposedly in one form or another, although of course repeat testing or repeat abdominal exams, return to the ED in 24 hours remains an option. It seems like it's a more scarce option than it used to be. So it opens up the conversation that for even some of those patients that may have appendicitis, certainly don't have a surgical abdomen, you could treat with antibiotics empirically and continue to observe. So I'm curious whether people find surgeons starting to suggest any of this. In my institution, not a one of them. But I think this is sort of the dawn of an era when we're going to see more of this. And this is only one article of many that are looking at this.
One of the ways the surgeons use it is like, all right, you call them, it's 2 a.m, they're like, well, start them on some antibiotics, put them into the OBS or wherever if you have a surgical OBS unit, or admit them to my service, and we'll see how they look after a little bit of that. And some of those, they don't take the OR. A lot of them, they come in, they still have a lot of tenderness, and they go to the OR with them, and the diagnosis has been confirmed usually by imaging at that time, but they use this as a way to preserve their REM sleep. Give them a trial antibiotics, let it cool off a little bit, we'll see what it looks like in the morning.
So, go ahead.
I saw that managed once by a surgeon in 1980.
You did what?
I saw that appendicitis managed once by a surgeon in 1980.
So this
Medically.
is not brand new. Yeah. So it's really interesting to think about what did it take to change our practice. It's not easy. We've been doing something a certain way for a long time. And at what point do we start saying, well, maybe there's another way of doing that? I don't know where we stand on this. This has been around for a while. It's gotten a lot of attention in the last 10 years, started to get attention in the last 10, 15 years. The Japanese published a few papers which said, we're doing it, it seems like it works. This is a pretty large paper. There's now a bunch in Europe from looking at it the same way. We treat diverticulitis non-surgically. Billy just said they're basically pretty much the same disease. So again, we're now trying to think of what's the pluses and minuses, and obviously we can think of possible minuses. You know, if you do fail, it looks like most people don't fail, at least for a couple of years. And usually the failures will be in the next week, in the next few days, so you can watch them really closely, and if anything happens, you can jump right in. But there is the worry that maybe there'll be some complications from it. You'll get perfs, and that'll be bad, and that's something that we are legitimately concerned about it. Although in most of the series where they talk about we did have to go in, they don't talk about any big long-term complications. So that's one thing. On the other hand, it would be sort of, you know, and another thing to say is that an appendectomy, particularly laparoscopic, is a trivial procedure. It's really not a big deal. So on the one hand, you could argue, look, why tolerate 10% failure rate or 15 or 20% when you could get pretty close to zero with a fairly small procedure? On the other hand, violating the peritoneum is the biggest cause of down-the-line bowel obstruction, which could be a problem. And it would be sort of nice if you didn't have to do it. So I'm not sure we have enough data to say for sure, but I bet you in 5 years there'll be a lot more of this.
Oh, but I think we've got some pitfalls here we don't know. Women who rupture an appy.
I was just about to go there. You don't want to lose an ovary.
Risk their ovary and risk their fertility, and that. So in women, I think it's a little dicier. In men, it's not quite as dicey. And I think in men, you don't need to image them as much, and you can take them to the OR because you can do it on your exam. But I think it's a little different in women, and I'm not sure where this is going to settle out. I think it's a fine option, but I think we don't know enough yet. And I think appies are literally, you're in the hospital, you're out of the hospital, you're having breakfast the next morning, and you go to work. And
so again, let me just finish what I was going to say, which is that I believe that while we will learn more, I suspect that we're going to learn more of the same. That it looks like it works most of the time, but not all the time. But in any case, I think this is rising to the point where now I believe it's something that should raise a shared decision-making discussion. It's not for me to decide for the patient. I can easily understand, and particularly in certain circumstances, if there's any question, if it's a woman of childbearing age, etc., where you might say, you know, you might be heavy on the potential advantages of doing the surgery rather than the other way around. But I think, you know, it shouldn't be for me to decide. I can easily imagine a rational person saying, lap appy, no big deal. You told me just took a look. I'll be eating breakfast tomorrow. Just do it, and I don't have to worry about it. But I could imagine another person say, you know, if 80% of it, 4 out of 5, you just give me antibiotics, I'll never need an operation. Let me try that. And I don't see why I should be the one to decide for them. I'll just mention one other thing, which is this got a little bit in the press recently when Rafa Nadal decided to take antibiotics instead of surgery so that he could play in the Australian Open, the number 2 or number 3 tennis player in the world. And he did that, and he played in the Australian Open and lost relatively quickly, more than expected. But in any case, I think we're now reaching the point where we should be thinking about, is this a shared decision-making process?
The final score was Appy 40, Rafa Love. There was also a hockey player that did that a couple of years ago and was treated so that he could continue in the playoffs. I personally am not quite ready to go with this. My own take on this is this is sort of a teaser article, an idea that's been around for a while, but I'm still consulting surgery and letting them do the shared decision-making with the patient. 21, I think, is maybe the most important article for you guys to read yourself. It's by a good friend of mine named Iona Heath, who is the former president of the Royal College of General Practice in London. And it's about overdiagnosis. This is a topic that I wrote a chapter for our course last year. Any of you who were here last year heard this whole, we spent a half hour on it. And I think it's really one of the most important concepts of that has arisen in the last 5 to 10 years. And one of the biggest threats to the practice of medicine, particularly in the future. It's bad now, it's going to get worse. It's about overdiagnosis. Let me try to be as brief as I can. The article itself
has a quote in here: "We have created an epidemic of disease without symptoms, defined only by aberrant biometrics." What is she talking about? Well, the classic example of this is prostate cancer. Turns out that prostate cancer, you've all seen patients who are dying from prostate cancer, a terrible disease. Some people get sick, diagnose prostate cancer, they're dead in fairly short order. But it turns out that when we discovered this sort of screening test for prostate cancer, we discovered that lots of men have prostate cancer. Way, 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 way more than were ever dying. We also discovered when people started doing routine autopsies that when you're an old man, you have prostate cancer in your prostate. If we go look on a routine autopsy, you died of heart disease, you have prostate cancer, and I mean, almost universal. And then it turns out the same is true with women with ductal breast cancer, and the same is true with thyroid cancer. They're now discovering, they got a screening test in Korea, the incidence of it went up 15-fold than 15 years ago, but the number of deaths is exactly the same. Now, how could that be? There are a couple of things you got to think about. One is that we have a new epidemic. It didn't used to exist. That's very unlikely for any of these things. Another is that we now have a great treatment. We're discovering it early and now we're treating it. There's no evidence of that whatsoever. Same is true, by the way, not just for cancer, it's true for PEs as well, where the exact same thing is true. We now do CTPA in everybody, and we're discovering 20 times more pulmonary emboli, and the number of deaths is exactly the same, and our treatment is exactly the same. So the only rational explanation for that is that this reservoir of previously undiagnosed disease really is disease. It's not false positives. When you look under the microscope, it really is prostate cancer, but it's a different type of cancer. It's not malignant in the clinical sense. Nothing ever happens with it. If we never discovered it, it would never present itself. The vast majority we'd never know about. So what do we get by finding it early? Well, we just hurt people. When we do prostate surgery, half of them become incontinent, and more than half become impotent, and nothing good has come of that.
And we terrified a whole generation of men there was a great paper called PSA Dynia, where they had a positive PSA that got followed, and it ruined their lives because they thought they had this devastating cancer, and they continued with ongoing surveillance after surveillance.
As we know now from all we live in a society of fear-mongering. We're afraid of everything, and we've changed all of our behaviors because children can't play in the playground. We can't have a playground because they might fall and hurt. It's crazy. But in any case, we live this way, at the airport, in all of our lives, and we live it particularly in medicine. We're all afraid. So let's get back to this concept. So it turns out that there are many diseases that we all have that come and go, that if you look really, really hard, you'll find them, and then they disappear without treatment. And they're not false positives, but they're not going to hurt you. So they're a disease only in a technical sense. But when we start finding them, now we're in deep doo-doo, because now we feel obligated to do something about it. It was something bad, and there we cause harm. And what are the most important characteristics of this? There are a couple of things to talk about. One is this article mentions the Will Rogers phenomenon. And the Will Rogers phenomenon is an important thing that you got to know about, because you'll read about it, or you'll read about its consequences, and you should recognize it. So here's the deal. When Will Rogers moved from Oklahoma to California, you remember he was the guy who did all that, he would lasso horses, and he got famous for that. He was the first guy who was famous for being famous. There's a few of them. Anyway, he was supposedly a wag who made these statements. He moved from Oklahoma to California, and he said the average intelligence of both states increased when he moved. And what did he mean? Well, he meant that he was the dumbest guy in Oklahoma, so when he left Oklahoma, the average intelligence went up. But because he was smarter than anybody in California, the average intelligence there went up. And we do that in medicine all the time, by redefining things. So if we lower the threshold for hypertension, for example, now people who used to be called normal but were sort of borderline and therefore had a little more problems than the other normal people, they moved from the normal group. They were the most risky in the normal group. So the normal group is now better because they got rid of the most risky group. But now they're in the hypertensive group, and they're less sick, less dangerous than the other hypertensives who have much higher blood pressure. So the average outcome in that group goes down too. Both groups get better, but nothing changed.
That's what we do by redefining disease. That's what we do with cancer screening. When we do cancer screening, we discover all these overdiagnosed diseases that never would have hurt anybody. All our numbers do better. It's magic. We're now treating cancer better. We didn't change one life. So that's one thing to understand that you're going to hear all the time. We're doing better. Our case fatality rate with PE is better. But we didn't, not because we're doing anything better, it's just because we define cases differently. The other critical thing to say is, why is this getting worse? Because it's about technology. We used to be able to diagnose cancer when you got really sick, and then you died, and then we looked. Now we diagnose cancer all the time with bigger and bigger microscopes. And so we're finding more and more of less and less, which is why an MRI, to me, is much more dangerous than a CT scan, even though it has no radiation. It finds all sorts of crap that has no clinical meaning, but which is true positive when you then do all the other stuff. And then we do interventions. And just think about PE for a second. Imagine when we get an electron microscope CT scanner. What did you learn in physiology? Some of you remember medical school. Not fondly, I know, but what did you learn in physiology about the normal function of the pulmonary vasculature?
It's a big filter.
It filters out clots, because we all have clots in our arterial vessels before they get to the central circulation. Once we get a good enough microscope that finds microscopic clots, we will all have PEs.
We're almost calling a rouleau PE now.
So once you start looking, I better get the test because the last patient, he looked fine to me and he had it. So now I can do it in everybody, and sure enough, everybody's positive. And we're going to have what we have currently already started to experience with PE. We diagnose a lot more, just as many people die, and more people die from the interventions. It's bad. So this is the concept of overdiagnosis. It's a wonderful article. I've written about this. There's a book by a guy named Gil Welch, which is a fabulous book called Overdiagnosed, I think is the name of it, if you're interested in the topic. But this is going to get worse until we start to address it. And the only solution is not to say, well, I diagnosed a PE, but I don't think it's important. Because once you start looking, this person, I think they might have a PE, and then I found a PE, it's going to be really hard to say, well, let's not do anything. The only way we can do this is, and the only real solution is to only go look where you're really worried. And that's where we've gotten into trouble, where we do all these screening and we do low-risk chest pain and once we redefine troponin to ultrasensitive, super, everyone will have a heart attack. And then we're stuck. This is important paper.
I would just say that in PE, when you look at the consequences of overdiagnosis, it changes depending on what the treatment is. But in PE, where the treatment is dangerous, it's anticoagulation, and so you're risking major GI bleeds, you're risking bleeds in the head, you're risking a bunch of things. We know that anytime you give a drug, remember that Y from medical school, intrinsic pathway, extrinsic pathway, common final pathway, every drug that works on the Y is a killer. And so PE is a disease that we've defined even, smaller and smaller blood clots, but the treatment has all the same potential for harm, and it's among the most dangerous treatments in medicine.
Can I just read two other great quotes from here that you have to know about? One is, she didn't write these, she just quoted other people writing them. One is a wonderful article by Ray Moynihan in the BMJ. Here's the quote: "Medicine's much hailed ability to help the sick is fast being challenged by its propensity to harm the healthy." And the other quote that I love is from a guy named McCormick in The Lancet in 1994. "General practitioners, primary care physicians, would do better to encourage people to lead lives of modified hedonism so that they may enjoy in the full the only life they are likely to have." And it's the opposite of American medicine, right? The complete opposite. Live in fear. Everything is about prolonging death. Don't anything you enjoy must be bad for you. We become the new Puritans.
When patients say, "I don't believe in doctors," they're in front of you, right, in the emergency room. "I don't believe in going to the doctor." When was the last time you said, "I don't believe in going to doctors"? It makes more sense now.
Well,
they're right.
Just one more quick point, because I've seen this repeatedly, that you make the diagnosis of that tiny PE, and then thereafter, every time that patient gets a little bit of chest pain, feels a little bit of short of breath, They come back to the ED, and then someone says, oh, they had that PE 3 years ago. They've since had 5 negative CT scans, but they had the PE. I'm getting the 6th one now.
Absolutely.
And in fact, the PE guy back east, what's his name?
Klein?
Klein did a study looking at just what happens when you have a diagnosis of PE, and even a workup for PE means that you're going to have more workups for PE than the group that has never had one in the future.
So, really important concept. The book is a great book, easy to read, fun to read.
22.
Same as 21, so let's do 23.
23. So we talked about X-ray, and we talked about, the ALARA thing where you change the dose based on the body habitus and size of the thing you're putting in the scanner. We talked about decreasing radiation exposure by deciding not to do a CT. Neither of those have anything to do with this paper, which is about this new technology that allows for ultra-low dose CT. This is all about the engineers, and it's all about the way they do beam collimation and what the net exposure is. Now, the history of this thing is fascinating. There was a company that needed to do whole body radiation on its employees every day. And that company was having a problem because they were worried about the cancers and things. And so they applied all of their substantial financial resources, and this company had some financial resources, to solving this problem and coming up with this way to X-ray the whole body as people left work. Which company was that? De Beers. If there's one thing you hate, it's when the goddamn diamonds walk out of your mind up someone's ass or in their cheek. So they needed to X-ray their people as they were leaving and find the diamonds. And so they actually created this technology. And this technology first led to what was called the Lodox. We have one at our hospital. It's a whole body X-ray. You can do an AP and lateral and load it up on the PACS and see in a multi-system, multi-fracture trauma patient what they got. It's great for doing baby grabs and child abuse too. But this is about this technology being spread to other things, and this is a paper looking at it. You don't have this machine yet. They're just getting out there. And it said that they could drop the radiation for a chest CT down to 0.52 millisieverts. This is somewhere about a tenth or a 20th, somewhere between a tenth and a 20th of current exposures for all these studies. A renal stone, you can get to 0.4 millisieverts. And a CT abdomen pelvis to rule out API with this machine is 0.56 millisieverts versus 8 millisieverts the old way, 8 to 10. So one of the things that we're getting at is these ultra low dose CT scans are coming. They're not routinely available. I don't know. As we've been doing this course and talking about this paper, I haven't run into anyone who has one in their hospital yet. But there is new technician that's about exposure control, they call it iterative recon, and beam collimation, which can dramatically decrease. Now, there is some loss of image quality as you go to some of these things, but this paper says that, the image quality is pretty well preserved if the engineers get it all right. Fascinating idea. I love the history of where it came from.
24, variation in use of all types of CT by emergency physicians. This is really a paper telling us, I think, what we probably all know that is happening all over. It's one emergency department following the CT utilization for patients aged 8 and older by 49 physicians, so a fairly large staff, and they just watched how often CTs were ordered and for what indication. Overall, there were about a quarter of the patients got a CT or more. Several of them, 18%, got more than one CT, and 5% got more than 2 CTs. So the mean was 24%, but the range was a threefold variation from about 11% to 33%. So meaning some physicians ordered 3 times as many CT scans overall as their lowest performing colleague. And then when you broke it down by indication, abdominal pain, chest pain, shortness of breath, there was up to an 8-fold variation. So that came in the chest pain category. The lowest orderers, 4%, the highest orderers, 32%. The degree of variability was mostly for those patients who were ultimately discharged, so that's where the biggest differences lay. And the head CT rate they thought was a reasonable surrogate. So those who ordered a lot of head CTs also tend to order a lot of everything else. And interestingly, this was not, and there was no correlation between experience of the physician. So it's not like the new people do this and the older people learn by experience and tighten up the ship a little bit. It seems like this is the particular practitioner's practice style, and it probably sticks with them forever. It raises a number of questions. Why are some people doing this and other people are comfortable not? You can talk about risk aversion, overestimation of disease prevalence, defensive medicine, and so forth. But the bottom line is there are people who are functioning at a much lower level of CT ordering rate. This study was not designed to look at any adverse outcomes by underutilization, but it's clear when there's up to an 8-fold variation for chest pain that there's at least some indiscriminate use out there.
Did they look at the rates of discharge versus admission for the high utilizers versus the low utilizers? In other words, are the higher utilizers having 50% higher discharge rate?
No, it was consistent. The high utilizers used more on the inpatient and more on the outpatient. It wasn't like, oh, I saved the admission by doing the CAT scan.
Yeah, and there's lots and lots of papers about this. I just, remind us that inappropriate variability is a big thing that we're talking about now. But there are some things where we don't know the answer, where variability is not necessarily bad. There's no clear right way to do it. So always keep that in mind. Always keep in mind that doing no CT scans is probably not a good idea, even though it's less than doing a lot of CT scans. There is a right number that isn't zero. On the other hand, what this and many, many, many studies tell us is that there are people who are whose default is to do lots of tests and who don't get anything from it, and that's a problem. I'm not so sure the stuff about who does it and experience is actually correct, because part of the way they measured it is wrong, so that the attending always got credit for the CT scan, even if a resident ordered it. And in these types of places, you're going to see those types of things are going to screw up your data. But in any case, it certainly is true that we have developed a pattern as a society where many people are ordering lots and lots and lots and lots of tests, and others are still ordering many fewer tests, and there doesn't seem to be any difference in outcome other than the harms created by the tests. And this is something that, is a broken record up here we keep talking about, and it's something to think about.
Although, to be specific, I would just draw your attention to the sentence right before the words conclusions there. I think this might be what you're asking. The greatest degree of variability in CT use for these complaints was noted in patients who were discharged from the ED rather than admitted. So there's some data in there about the focus, which you ask about. So there is some element of that there. 25, red flags.
25 is a paper that makes a claim that it really doesn't, that's not really relevant to us, and I don't really want to spend a lot of time on it, except maybe the opposite of what it's claiming, and to point out that there's a great deal of what's published out there that asks the wrong question. So 20 years ago, a fellow named Rick Dio wrote a famous paper about a guideline for low back pain, and said the way we should look at low back pain is we should decide what are the things we can't afford to miss. And then we should decide those things, how do we recognize them? And he called that red flags, things that you should worry about and make you think, oops, I better worry about that. So, for example, if you don't want to miss a fracture, a red flag is there was trauma, or it was tender right where you pressed. Another thing you don't want to miss is an epidural abscess. So if they had a fever and it was tender right in one localized spot, those are things that suggested that. And you could think of many other things that are associated. Cauda equina, what are the things that make me think of cauda equina, et cetera, et cetera. I believe this is not only the best guideline ever written, but it's also how we should practice in all of emergency medicine. Somebody comes in with throat pain, sore throat.
Well, what are the things I can't afford to miss? Very few of them, but there are a couple. I can't miss epiglottitis. I can't miss a retropharyngeal. What would make me think of that? I don't want to start doing tests on everybody, but which ones would I start thinking, you know what, this could be more than just your average sore throat? Same with chest pain, same with whatever it is you're interested in. That's how we actually should be practicing, I believe. So back pain was the one where this notion of red flags was defined, and they came up with a bunch of red flags, things that you really want to, should heighten you to, I better look further. I better look further, and it's converse. I don't need to look. It's fine. Whatever it is, I can miss it today. It's not a big deal. It's either benign or something that'll still be there tomorrow, and it's not an emergency. That's a clinical question. That's very different than the question that this paper asked, which is, which of those red flags, when you have it, predicts a high positive predictive value that they're really, really sick? And so that's what this paper does. And it says, you know what? If they're tender, trauma does not predict that they really have something important. So we shouldn't include it in red flags. It's the wrong question. Of course it isn't a high positive predictive value. It just is the wrong question. The question I want to know is, which ones? I'm done. I don't have to do any further testing. And the red flag approach to that is actually a brilliant approach to that. This says that even when they have a red flag doesn't mean they're really sick. So what? I don't care.
And I would remind you that this is just looking at red flags for malignancy, right? There are other red flags. So there are red flags in back pain for infection, for example, which are fever, HIV, immunocompromise. So this is in all the red flags. When you're doing the red flag approach to low back pain, it's trauma, it's infection, it's malignancy.
If you don't know this guideline, you should
Tuna
get
fish.
it.
So I always chart tuna fish negative, and I
trauma,
drag red.
unexplained weight loss, neurologic signs, age greater than 50, fever, IV drug use, steroids, history of cancer. Tuna fish.
So that's a great way. That has all the categories of
You
red
know, he was
flags.
just writing down tuna fish. I'm sorry, I don't usually go on my phone, but I just looked up the mnemonic.
Tuna fish negative is a nice, clean way to say we look for the red flags across the categories.
We see a billion of these, and it's a great way to avoid doing unnecessary tests is to go through the red flag approach. And we should all know it, easy.
26.
26. How many of you are using IV Tylenol?
None. You got it?
So actually, this hands high because it's actually not too many people. And what's interesting is when it first came out,
IV Tylenol.
IV Tylenol. 'Cause when it first came out, I thought, really, seriously. Although it makes some sense that IV Tylenol would have an effect. Tylenol has an effect, and the first pass part of it's taken out when you give it IV instead of orally. This is a paper that looks at It's a Turkish paper. It has a third drug that we don't have available here that they compare to, and it's people with low back pain. And it just looks at using this. IV Tylenol versus morphine, which is considered sort of one of the great opioids that you can actually use to treat painful conditions. And it basically found that a gram of IV Tylenol is equivalent to a decent dose of morphine, 0.1 per kilo. One of the things that Billy mentioned earlier today, I was sitting in the back listening, the idea of the straw man phenomenon, when papers compare their study drug to something that's weenie dose of something else. It's not an adequate dose. This is sort of the low effective range of morphine, the 0.1 per kilo. The range is supposed to be 0.1 to 0.2. It's in the low, but it's still in the range of what should be effective. So they chose a decent dose and found that the IV acetaminophen was equivalent, which is interesting. I wasn't sure this would be such a big splash of a drug, but it gives you an option of a non-sedating pain control agent. It's just interesting to me that it hasn't particularly caught on, and I think one of the reasons is it's flippin' expensive. Compared to morphine, which is dirt cheap, it's manifold different, orders of magnitude different as far as cost.
So there are a few things that you should know about this that are conceptual, whether or not you ever use IV Tylenol. So one is that when you give the dose IV, you get a blood level that's about 50% higher than the same dose given orally. So, and that's because of the first pass phenomenon that Diane talked about. So that means that you could get the same pain effect, almost certainly. It means that giving more increases your analgesia because there are now half dozen studies of IV acetaminophen, and they all show the same thing. And that's more than you would get with the same 1 gram dose given orally, which means that giving more, getting a bit bigger blood level, gives you more bang for your buck. We don't have a ceiling effect with acetaminophen the same way we do with NSAIDs, where giving more oral NSAIDs doesn't make pain better. You have a ceiling effect at about 400 milligrams of ibuprofen. Except for inflammation, for pain, it doesn't get any better. So giving more oral Tylenol, to me, that's an important concept because I'm pretty sure that the doses we use are trivial. They're teeny. And that if you really want to hurt somebody with Tylenol, with acetaminophen orally, you got to give 15 times the standard doses. So if we just doubled our dose from 15 per kilo to 30 per kilo, we would get the same effect as giving 0.1 of IV morphine. Second thing to say is that another advantage of IV morphine, besides being consistent and cheap and safe, is that you can titrate it, right? Now, you probably could do that with acetaminophen too, but it's important to know about 0.1 per kilo of morphine. There are many, many, many studies that show that about 50% of patients, it provides adequate relief, which means it's a really good starting dose because half the patients will be enough. But it also means that it's not the standard. Half the patients need more than that. So when you're using morphine, it's a good way to start and then give more as you need, as long as you don't wait an hour. Give more in 10 minutes because the maximum effect is in 10 minutes. So you can start with 0.1 per kilo and then go up 10 minutes later if you need more. The other thing is it points out that 1 gram of acetaminophen IV is as good as a good starting dose of morphine, not as optimal analgesia. This is only exists because it's expensive. That's why we have it. We could recapitulate this orally. We're scared to because there are all these warnings about, oh my God, you'll kill people if you give them a bigger dose of acetaminophen. The evidence is overwhelmingly clear that that's a lie. Acetaminophen is the safest drug ever invented. Maybe the only exception is morphine. I mean, incredibly safe drug, and you have to give way, way higher doses to cause harm, but we're all afraid to give appropriate doses.
Question.
Was the rescue medication required 30 minutes additional acetaminophen or
Morphine. It's always funny when people are trying to replace morphine when everybody acknowledges that actually the gold standard is morphine.
A place for this might be those opioid tolerant patients, and you're looking for some other analgesia. It's sometimes hard to find that really high dose of opioids for them.
27.
27 is it's not earth-shattering. It's a randomized controlled trial at Stony Brook with about 90 patients in it, so a small thing. Well, they just said we gave them 800 of Motrin or a gram of acetaminophen, PO, or the combo, and saw which worked better. And all the patients had pretty similar pre-treatment pain scores, and an hour later, almost all of them, the patients had a pain score drop of around 20, so they seemed to be comparable. And there was a little bit less rescue medications in the combination group, but the conclusion of the authors was, really, in terms of acute pain relief, the combo was not that much better. So use one or the other. You're going to use Motrin, use Motrin. You're going to use acetaminophen, use acetaminophen. And to me, if it's one or the other, use acetaminophen. Motrin is a drug that has a much higher complication rate, renal, GI, etc.
Yeah, and just remember, this is a little bit of a straw man. A gram of acetaminophen is too low. That's a chintzy dose. 800 of ibuprofen is
max.
Way over the top. And I'll just point out, I've said this a million times, some of you have heard me say it, there are only 3 conditions where there is evidence that there is an extra effect of NSAIDs besides their analgesic effect. There are many, this is 90 patients. There are a zillion papers with lots and lots of patients. For most common conditions, we're looking at analgesia. There's absolutely no difference between maximum NSAIDs and minimal acetaminophen. It's not better. So the only place I think you should be using an NSAID is where it's special, where you're not looking just for analgesia, you're looking for anti-inflammatory effect. And it turns out that's much less common than most of us think. Where is there an anti-inflammatory effect? Not you, Billy. There are 3 conditions where there's really an anti-inflammatory effect. Gout, rheumatoid disease, any rheumatoid disease. That's why when they take aspirin, they don't take a gram, they take a ton. You need more is better for anti-inflammatory. Where else? Colic.
So these
renal
are
and biliary colic, prostaglandin mediated. Their NSAIDs actually have a special effect. And the third one is menstrual cramps.
premenstrual syndrome. That's it. Now, not everything's been tested, so maybe it's true of pericarditis. I don't know. But it's been tested in a lot of things where you'd be shocked that there's no inflammation. Osteoarthritis, no inflammation. Back pain, headache, fractures, Achilles tendonitis. It's an itis. It has to be. No, there's no difference. So for most things, I think we are fooling ourselves when we use NSAIDs, and the putative harm of acetaminophen is that over 50 years it's caused 50 cases of liver failure when you take too much, which most of those I think have nothing to do with the acetaminophen. But even if all were true, compared to NSAIDs, 17,000 ICU bleeds a year in the United States. I mean, it's crazy. Why would you use an NSAID except in those three conditions, or maybe one where it's not been tested, like pericarditis? I think we should rethink this.
Both of them. They had 20 milliliters on the VAS.
They both work. They're very comparable. And my point is, if they both work, use the safer one.
And 20
That's
millimeters,
Tylenol.
20 millimeters on a VAS is not maximum, but it's pretty good.
Tylenol.
Well,
See, so what
that's
that
the
does.
placebo effect.
So that brings up the placebo effect. And one of the things that's interesting to me about the placebo effect, which tells me that you need to do some cheerleading when you prescribe these sorts of things, is that when they do studies looking at placebo has about a third efficacy, just the placebo itself. Wow, you gave me that drug, I feel so much better. It was a sugar pill. But whatever that psychological placebo effect is, and about a third of them will have side effects. That pill you gave me, that turns out to be a sugar pill, gave me nausea, gave me itching, a rash, whatever. So this cheerleading part, I think, is a big part of the whole acetaminophen efficacy thing, is to basically tell people you can spin it. You need more than that 650 that's on the bottle. You need a gram. You can really just spin it so it sounds.
That's
Exactly.
That's really important. So the good news is you can say, of course the Tylenol didn't work for you. You weren't taking enough. And then you want to make it, that dose is not adequate. You need the real dose. And then to make it even better, you have to show them that it's really a powerful, dangerous drug. So you say, weren't taking enough. Now that doesn't mean you can take as much as you want. You can't. It's really dangerous if you take too much. Which is a lie, actually. It's not that dangerous. But you could say, that doesn't mean you just swallow the bottle. It means you take these 4. And so it's amazing that nobody thinks acetaminophen is as good as an NSAID until they don't know which one it is, and then they can't tell the difference.
Comment back.
Yes, regarding your recommendations about acetaminophen, what do you advise your patients on how much they should be taking?
So I take for myself, I take acetaminophen a lot. That explains a lot. I take 2,500 milligrams myself when I take it. I don't tell anyone to take that. That's a lot, but I'm sure that it's safe. That's why I take it. I'm not trying to hurt myself. So I tell people 20 to 25 per kilo.
We ultimately, our ethics committee, talking about this placebo effect, ultimately our ethics committee took it off the formulary, but for years, and when I was a resident at the county, we had Obelcalp. 10, 20, and 40 milligrams on the formulary.
You know what
Obelcalp
Obelcalp
is
is?
placebo spelled backwards. You're like, oh, I'm going to give you the 40s.
There's a study recently that tested the effect of placebo when the patient knew it was a placebo. They gave people placebo, didn't tell them anything. They gave them nothing, and they gave them something where they said, this is a sugar pill. It doesn't actually have any medical effect, but it has been shown in many studies to work very well. And the results were what you expect. Nothing didn't work. Placebo worked pretty well. Placebo, it worked just as well when they said, it works.
It's better if
This
it's a
stuff
blue.
works.
It's
This
better if
stuff-
it's a blue pill.
Yeah, that was the other thing about county. In the old days, it used to be they were colored, and people would, it wasn't just that you got Obelcalp, but there was Lac A and Lac B, and one of them was purple, and that meant really strong. People came in asking for it.
The purple pill.
I want the big purple one.
Nexium blew that out of the water.
Abstract 28, adherence to PIOPED 2 investigators' recommendations for CTPA studies. So This is a study, I don't think it's worth getting into the actual data because it's a retrospective implicit chart review, no methods. And they tried to discern, for instance, what the pretest probability of a patient was for PE on a retrospective chart review. And then they were also trying to determine whether the patient or the physicians paid any attention to a revised Geneva score when that was not required prospectively. But I think the take-home messages are worthwhile, that if you have a patient who has a low pretest probability, then I think even this is debatable. We had this whole topic last year. There's certainly a very low-risk patient population that you can just stop. And a lot of people debate how you find that. And certainly many people are using the PERC score, and if people are PERC negative, we're generally comfortable stopping the workup there. Others have also advocated that a Wells score of less than 2, 1.5 or 1 or 0 is another place that you can stop. But in any case, if you have a low pretest probability and you opt to go get a D-dimer, and the D-dimer is negative, there's absolutely no justification for then going on and getting the CTPA gram. And even with the more moderate risk patients, where traditionally we've been teaching that those patients, you can't believe the D-dimer and you're going to need to get the CT anyway. ASAP recently came up with, granted it's quality C guideline evidence, but their recommendation was, even for the moderate risk patient, a negative D-dimer study is an appropriate endpoint for your workup. So clearly we're way overworking a lot of our patients up. There are too many D-dimers being sent. But even in that population, many patients go on to get the CT with a negative D-dimer, which is just craziness.
So this is all about Bayesian thinking, which is how you should use tests. And Bayesian thinking says a test doesn't tell you an answer yes, no. All it does is change your prior probability. A negative test makes it less likely to have disease. A positive test makes it more likely, but only to the extent that the test is a good one. A really good test changes it a lot. A bad test changes it a little. And tests aren't equal in both directions. Some tests are better when they're negative, and some tests are better when they're positive. Some are equally good. The concept here is that a D-dimer is pretty sensitive. That means it finds it when there is disease. It means there are very few false negatives. So a negative is pretty good, lowers your probability pretty good. It's so nonspecific that a positive is useless. It doesn't really change your risk positive much. So then how do you use it? It depends upon where you started. And that's where this concept of low, medium, high probability comes in. The reason that people are now talking about moderate probability is not because anything has changed, except for the number of people whom we call moderate who actually have the disease. So go back 30 years ago when Eugene Robin wrote the most important paper on this topic about the emperor of embolism with no clothes. In those days, a low probability clinically meant 10 to 15% ruled in. Medium probability meant 30% ruled in, and high probability meant 60% ruled in. When Wells did his first study and defined the Wells criteria, 10 or 12% of the low probability patients by the Wells score had the disease. If you follow Wells's studies, that kept decreasing in each subsequent study. To now, the last handful of studies, a Wells score that is low probability is 1 to 2% have the disease. And moderate probability is 8 or 10%. So if the rational use of a D-dimer is in a low probability patient defined as 10 to 15%, we're now calling that a moderate probability patient. Why is this important? Because the only rational use of a D-dimer is if you start with 10% or so, and it's negative, you're now down to 2%, stop. The only rational use is in that group with 10% started, I don't have to do a CTPA. It's not a lot of patients, but it should lower your doing the CTPAs by a little. Where it has been studied, every time that a D-dimer is introduced, the number of CTPAs goes up twofold. It's the exact opposite of what it should be doing. How did that happen? Because we're not doing it in 10% low probability, we're doing it in 2% low probability. And when you do it in them, there's so many false positives that now look what you've done, Ollie. Now you have to do a test. And
and we do many more tests. So either you should not use a D-dimer at all, give up, or you should say, I'm only doing it in however you call a person who I don't think they have it, but there's a real chance they have it. That's what we should call low probability. If you're doing it in, this person doesn't have the disease, but I'm afraid of sending them home, then you're only asking for trouble.
One of my favorite articles written by Steve Green in Annals 2012 talked about a few things. It was called Right Sizing Testing for Pulmonary Embolism, Recognizing the Risks of Detecting Any Clot. We've talked about this somewhat, but a couple points I wanted to emphasize was, one, so many of these people where we consider the disease that are clearly very low risk, they have no physiologic derangements that we can see in front of us. They're not tachycardic, they're not tachypnic, they're not hypoxic, they're not hypotensive. So they look just fine, and we're starting to think, could it be a PE? We have this notion that we have to make the diagnosis today. But really, if you look at that kind of population, the bad outcome is almost zero. So he talks about employing the strategy of watchful waiting, or what's also been called masterful inactivity, which I just love. And toward that end, he had essentially a dot phrase, a macro that you can just load into your chart. And I have put this in my documentation, and it's given the known potential harms of a diagnostic evaluation for pulmonary embolism, my clinical judgment for this patient is that those risks currently outweigh the likely benefits. And then if you're deciding to use this watchful waiting approach, you could potentially add, instead, I have asked the patient to be rechecked in 24 hours or earlier, if worse, to reassess this risk either in the ED or with his or her regular physician. So I've plopped that into patients' charts even before the D-dimer. I don't want to know the D-dimer. I don't think the patient has it. Let's just see how he or she's doing in a day or two. And I think that's a very legitimate and safe approach.
It also, what we talked about before, also should remind you that the Wells score is used because it's objective, right? But it's not objective at all. 10 years ago, a low-risk Wells score meant 10% chance of disease, or 15 years ago, and now it means a 1% chance of disease. And why is that? Because there's that one question in the Wells score that gives the whole thing, makes it all silly, which is, do you think it's something else? That's not objective. And in fact, that actually, if you there have been studies which ask people to do the Wells score and then just ask them that one, and then looked at the outcome according to the Wells score and the outcome according to, forget the rest of the Wells score, just that one question, and they were identical.
When I hear that quote with the masterful inactivity, it reminds me, for those of you who are old enough to have read it, in The House of God, where when the fat man was asked to define what internal medicine is, he said to the intern, it's doing as much of nothing humanly possible and ultimately taking credit for the cure.
29, we really talked about this great paper about overdiagnosis of PE, makes the point that we're now diagnosing, in the era of CT, we are diagnosing it way, way more than we ever did. There's no effect on the number of people who die or get really sick from PEs, but we are way increasing the harm from anticoagulation. And that's overdiagnosis. It's not that it's not there. It is really a PE. It's just not an important PE. It's not a disease.
Yeah. So part of this, all these sort of shenanigans that we go through mentally, these gymnastics about what to do about PE, I have my own approach to how I do this, that I do it every time, sort of standardly. I can tell people exactly how I approach PE. And one of the things that's integrating into this, because D-dimer does have a role, you have to use it correctly, in the low-risk person, but it does, or moderate risk now if you want to extend it, it does have a role. The problem is that we know that there are certain populations or certain times of life where your D-dimer increases. And can we integrate that knowledge into using cutoffs for D-dimers depending on the individual patient population? One area of that is pregnancy, and I'm not going to get into that because I honestly don't think that's ready for prime time yet. I don't think we have enough data to know where the cutoffs are that are safe at certain trimesters of pregnancy. However, we also know that as you get older, you have sort of a likelihood of a higher level of D-dimer to be normal for your age. One of the things they've looked into, and actually Bill and I were just talking about this, we both have integrated this into our practices at our institutions, is using age cutoffs for D-dimers to determine whether it's a positive D-dimer or a negative D-dimer. And an age cutoff is basically after the age of 50 is your age times 10. Okay, and if you want to simplify it, you can even do it by decade. But it's basically age times 10. And you can use that as a cutoff. And is that a safe practice? And what this paper says, as well as several others that are out there, and the champion of this has been Jeff Klein, who's done most of the sort of looking into this, is that what it does is makes your testing group much smaller. So if you use these age cutoffs, and with no sacrifice of endpoint, that you actually, and people still do find it. Actually, one of the things I wanted to build on a little bit that David said earlier is that what we really care about is there a PE there? What we really care about is what happens to you a month from now, 3 months from now, a year from now. Even if you had a little PE, if you're going to be fine, I don't want to go find it. I really care about is the PE that you have going to cause you any sort of clinical problem. So we're changing what's the sort of gold standard endpoint here from is it there to what difference does it make to you clinically. This is another way to get there, which is to use a D-dimer cutoff that's age dependent, and that way you actually decrease the number of people you go charging ahead to do testing on in a way that turns out to be safe.
So I have one caveat on this. We'll take a question in a second. And we do the age-adjusted thing, so we're using 600 and 700 in the older patients. With this caveat, they can't be on a novel oral anticoagulant. If they're on dabigatran or rivaroxaban or apixaban, those drugs, all the novel, but particularly the Zabans, it's not clear whether the direct thrombin 2A inhibitors do it as well, but the 10A inhibitors all lower your D-dimer level. So if your oldster that you want to use this is on a Zaban, I don't know what to do because there's no data on this.
What are you going to do if it's positive, if they're on an oral anticoagulant?
If they're on what?
On
If they're on a
oral
Zaban? Yeah, no, I don't know. But I'm just saying, just understand that the D-dimer is lower in people on Zabans.
I want to point out that there are three big groups studying PE. There's the group in Canada with George Wells. There's the Jeff Klein and his group have been doing a lot of studies, and there are the people in Europe, mostly in Geneva. And the big difference between these is that the studies from Europe, the number who rule in is 20%. And in America and North America, it's 1 or 2%. We have a very different notion of what PE is. So in this study, which is from Europe, they looked at low-risk Wells score. Remember, Wells score is objective. Low-risk Wells score in North America, 1% rule in. Overall, in this study, 19% of the low-risk patients ruled in. And they're claiming they're using the same score, which shows you how subjective it is.
Yeah, the Geneva. It's interesting to watch the Geneva people and the Wells score people fight in the literature.
And
There were a
it's
couple
the
of
same
comments
reason,
somewhere
by
I
the
said-
way, that the PERC score, when you apply it to the European
We'll get to you in a
population
second.
patient, doesn't work.
We'll start with you, and then we'll come over to here.
Quick question. So you found a PE which in your mind is not clinically significant. Are there any circumstances where you do not treat that at all?
So that's been discussed, and people have suggested, including the old gurus of PE, Paul Stein and Russell Hull, the guys who did the PIOPED study, who said, you know what, maybe we're finding too many of these subsegmental clots and we shouldn't be treating them. Maybe we should just do watchful waiting. And that's a thought. I'm not very happy with that thought, because if you went looking for it in the first place, why were you looking for it if you knew that if you found it, you weren't going to worry? In addition, it turns out there's a study from Europe where they looked at subsegmental clots versus bigger clots, and they found no difference in outcomes. They both had the same outcomes 6 months later. And what was the big difference? The big difference was that in that study, over 20% of the patients ruled in. That means they were using European criteria where they were only looking in people who looked sick. So when the person, and we all learned in medical school, it's not this clot that kills you, it's the next one. So if you're looking sick and this clot is small, but the next one might be a big one, or you might throw a sour of emboli, that's a big deal. The real issue is not the size of the clot, it's how sick the patient is. So I think once you've found a clot that you don't think matters, it's really tough. I don't know what you tell the patient. I don't know what you tell. If we're going to sit on this, I went looking for. I think for me, the real decision has to be made before you go looking. Am I worried about this patient? If I'm worried about this patient, anything I find, I worry about. If I'm not worried about this patient, don't go looking. That's what I believe.
I've had a few patients getting a CT belly with IV contrast, and then the radiologist was reading
Oh, yeah.
PE in the left lower lobe.
yeah.
What the hell do I do with that?
Yeah.
So I don't know.
It's like the head CT that comes back with whopping sinusitis. The patient has no complaints whatsoever. Go ahead. There was another comment.
Can you explain the age-adjusted D-dimer values again?
So in
10
our
times the
lab,
age.
Over the age of 50.
So it's 500 is the usual cutoff.
Yeah, and ours is
600 for a 60-year-old, 700 for a 70-year-old.
Right.
so in other words, you got a 70-year-old. Their D-dimer comes back. They're 71.
640.
It comes back 700. They were low probability to begin with.
You're done.
I'm done. No CTPA.
That's validated?
Yes.
Yeah.
Well,
Could use more. Could use more work. But you have
But
to
actually,
put.
no,
you
it's
have to
actually
put,
pretty good.
You have to put it in the context that if we're saying we're overworking people up, if I have a tool that'll help me work up less, that's got some EBM behind it, the question is how much do I need to grab that tool? I'm grabbing that tool.
I
right
told
now.
you on day one that there's a big difference between sensitivity and negative predictive value. And this is validated from the standpoint of negative predictive value. If you use these cutoffs, they're safe in the patients we use them if they're negative. But that's the only way that's been validated is in terms of its negative predictive values. And that's partly because very few of these patients are sick, period. So whatever cutoff you use would work. Whether they actually are sensitive, I don't think is validated. But I agree with Billy that if you're looking for a reason not to do the test, you really don't think they have it, at the very least, this is a help. I would suggest more important is to say, don't go looking.
Well, and it's also, PERC doesn't apply to this age group, right?
Right, they're
one of
over the PERC age.
They're over the PERC age, so you can't use PERC in this group. So it's nice to have sort of an alternative pathway that seems to be safe.
Comment.
You tried to treat cancer patients, successfully treated cancer.
Well, I think it
I don't
depends
know.
on the
I don't have an
cancer,
answer for that.
actually.
so, but your point's a really good one, which is that cancer automatically makes you not low risk unless this is not a P. It has nothing to do with it. The patient came in with pneumonia, or the patient comes in with something that, vaguely related to the chest, but they're a cancer patient, I automatically include them. No, you don't have to. Not every cancer patient has to be worked up for PE. But if you're thinking PE and they have cancer, that automatically makes them higher risk.
So the D-dimer wouldn't be useful.
But not, it's sort of like tests. I'm sure I did this with tests. I do this with all my residents. People, an 82-year-old comes in with nothing, but it's in the chest, nothing. But it has nothing to do with heart disease, and they have a history of heart disease. And junior people often say, well, I had to let's do a coronary workup. It could be ACS because they're high risk. Yes, they're high risk, but they're high risk tomorrow and they're high risk yesterday, and this has nothing to do with ACS. This atypical chest pain that lasts for a second and hurts when I turn is not ACS. You don't have to work up every high-risk patient. Same with cancer. If the presentation is not a PE, don't go there. If you're really worried about PE, cancer seals the deal.
Paper 31, can we move? All right, 31 is a British critical care doc who's waxing and waning philosophical about some of these lung protective ventilation strategies, which have traditionally been used when people are failing ventilators, just before they get high frequency jet ventilation. And he talks about a couple of these, and they're things like lowering your tidal volume, using alveolar recruitment methods like size and manual exhalation and yawning kind of things, using lower PEEPs, and paying attention both to your peak inspiratory pressures and your plateaus. Plateau generally better than PIPs, but paying attention to this. And I'm a big believer in all of this, and he says this is not just for people with ARDS who are likely to go on to, to a situation where they might die. We should be doing this on pretty much everyone we intubate. And I have no objection, although, to that, and I think it's the right thing to do. I just think from what we understand of that physiology, this is the right way to go about that business.
Okay.
I thought I was going to get shot down for that one.
No, I agree.
I thought this was going to. All right, good.
Not
Let's
from
move.
me. I agreed with
All
you
right.
last week on this. So
32, high-flow nasal prong oxygen therapy or nasopharyngeal continuous positive airway pressure for children with moderate to severe respiratory distress. This is not really a study. This is just a report. This is what we did. This was a ICU in Melbourne, Australia. looking at their first form of respiratory support when simple nasal cannula oxygen was insufficient for these babies who were average age or median age 5 to 6 months old. And some of these kids got CPAP, which is, I think, the older, more traditional approach. And some of the kids got this new one, which is high flow, humidified, heated oxygen at a rate generally of about 2 liters per minute per kilo. So that means you're hooking a 10-kilo baby up to a 20-liter flow, which is not just the same as turning up the wall oxygen. This, in many places, is I think you can make your own, but it's usually a proprietary system that your hospital purchases, and now you have the capability of delivering this high-flow, heated, humidified oxygen at exceedingly high rates, but these rates are remarkably well tolerated. In this report, the need for sedation in kids getting CPAP was almost twice the need for sedation in little kids getting this nasal prong oxygen. The CPAP kids, for whatever we take from that, were on the CPAP much longer than the nasal prong kids. They had higher rates of complication like barotrauma and oral trauma. And it was largely hey, this is kind of new. We kind of like it. It seems you could use this in the typical type 1 respiratory failure where it's not a ventilatory problem, but it's a simple oxygenation problem. And although this study certainly can't be used to support it, it is used in adults as well. So I have yet to see this hit my emergency department. I know our ICU has it, and I think this will become a form of treatment that we can turn to, just as CPAP has been for the last 15, 20 years, when before we didn't have that either.
PGM people think this is a big deal.
Yep.
So when you talk to them, they really think that having the ability to the device is no big deal. It comes on a little roller. It's like this. It does the humidification and heating of the air. So it's just a widget basically. But the PEDS people are pretty excited about this as ease of use in some of these kids, and with a little bit of nasal cleanup, because sometimes the reason the kid's hypoxic is because they're just filled with boogers. But after a little nasal cleanup and stuff, if they're having low sats, they want to go right to this.
I'm a big fan of less is more, and I hope this works out. CPAP and any of those, any of the non-invasive ventilations is a little bit of, unpleasant. People don't like it. So if we could find a way to avoid it, it would be great. I don't know of any real data about this yet. And I don't know whether this is a one-size-fits-all. Are there some places where you really need NIV and other places where this is just as good? I don't think we're
Have you ever
near
put
there
the
yet.
BiPAP mask on to see what it feels like?
Oh,
You feel like a dog with your head out the window at 70 miles an hour on the freeway.
it's terrible.
It's like the tornado up your nose.
And one of the key things is if you're putting this on, you've all done this, you try to put it on a patient. If you try to slam it on their face, there's no way you're going to do it. Really, the best thing is to have a respiratory therapist who's really good at gradually introducing it. If you just try that and then have the patient do it, it's way, way, way better. Trying to force that on them when they're already hypoxic and a little paranoid is really a bad idea. Number 33 is a terrible study about making the claim that ultrasound is really good. Focused exam with the ultrasound on the heart, lungs, and deep veins for acute respiratory symptoms is really, really good. I don't want to go into the obvious reasons why this paper doesn't prove any of that. It basically says we used it and liked it. But I will, since I'm not an expert at ultrasound, I'll open up to anybody who wants to make comments about the utility of ultrasound in this. I'd only make the caveat that I personally am worried about overdiagnosis with this. But certainly it's a tool to be used. I don't know exactly how to use it.
So I'm a big believer of the rush exam in patients with shock, which is about acute respiratory symptoms. Got much less experience with it in this setting, but I'm a big believer in the other realm where I think that undifferentiated shock can be difficult to sort out, and that the rush exam, which is sort of what they're talking about here, can sort it out. But other than that, I don't think this really gets you there. But this is another example of what I was just talking about earlier to the whole group here, which is that in Europe, they're way ahead of us on this stuff.
34 we'll talk about in the next half hour, so we'll skip it here.
Well, let me just add one comment on 33. I think the way they did this was that they had this was the ultrasound doctor who, not involved in the primary care of the patient, came and saw the patient, and the median time for the evaluation was 12 minutes of rolling the gel and the probe over the chest, front and back. So I think that in itself would speak. If the expert's taken 12 minutes to do this, it's maybe not quite ready for me to do it.
And it also points out a big difference of how ultrasound is done in Europe versus here. If you send someone to an ultrasound suite, the tech does the ultrasound and snaps some images and a loop for the radiologist to read. In Europe, the doctor, the radiologist, comes to the bedside with the machine and does the ultrasound themselves. I think those are dramatically different processes and are going to produce dramatically different results. But a rush exam is something you do as an emergency physician at the bedside, and that's a conversation for another day.
Actually,
34.
34, 35, and 36.
Good. Knock 'em all out.
In the next lecture. So unless you guys have things you want to say, we can talk about those.
No.
37 is one of many papers. This is a meta-analysis of 5 randomized trials of 22,000 patients looking at heparin and heparin equivalents versus placebo in stroke, and any decrease in harm from the infarct itself is overcompensated for by increase in major bleeding. So it is now several years since everybody has agreed that heparin is not an appropriate treatment for stroke, except in legal cases where there are, or I've read many testimonies where the doctor committed malpractice because they didn't give heparin.
Really?
Yes, it's bizarre. Yes, because unfortunately I get asked to defend doctors all the time about TPA, and periodically there'll be one of the plaintiff's experts who says, no, TPA was indeed inappropriate, but you should have used heparin. So it's pretty bizarre, but I say that only as we shouldn't practice for lawyers and malpractice, but despite the overwhelming clear evidence that heparin is inappropriate for stroke, there are still, quote, experts out there going around telling us that we're failing. And that's particularly true if the stroke was caused by a dissection. I love this concept because for dissection, I've read many testimonies that the failure to use TPA in the dissection, the carotid dissection or vertebral dissection, or the failure to use heparin was what killed the patient, you moron doctor. And I love the concept that it's life-saving if you do it for a dissection up here, although it's malpractice if you do it for a dissection over here. So how did that what's the physiology of that?
38.
38 basically says that, the ACLS guidelines, the last iteration that came out, basically said that you can do just chest compressions for cardiac arrest, that you don't need to do the rescue breathing with that. A lot of reasons for that, but there's a good database that says you actually do better with that. Your outcomes, your likelihood of death is a little bit less if you get chest compression CPR
You do
only.
uninterrupted compressions.
Uninterrupted compressions without any rescue breathing going on. And there's the passive ventilation that occurs with CPR anyway, with the chest compressions itself. This is a paper that basically says your outcomes are better. And this was it was a randomized trial. They did it dispatch, sort of teaching people how to do it, doing the staying alive. The cadence for CPR, the song Staying Alive, back from the Bee Gees back when, is the cadence you can use to do the right compressions. Ironically, the same cadence is in the song Another One Bites the Dust. So if you're going to hum a song during CPR, don't hum Another One Bites the Dust and have the family hear you. You want to hum Staying Alive.
I like that idea.
Yeah.
And I don't know
You
if
might want to tell them something.
And I don't know if you've seen the
Another one
YouTube
bites-
video. So there's the one with the Asian guy who's
yeah.
the internist, who's the comedian from
Yeah.
Night in Las Vegas. And then there's the British one where it's the sort of thug British one. He says, well, first to show you CPR, I need a body. I happen to have one of those nearby. And they slide their skiff out on the loading dock.
It's a great video.
You press on the sovereign, and they do. So there's been these educational, hands-only, compression-only CPR videos,
This
and
is for the
they've been
lay
really.
public. They're hilarious.
So if you want to go to YouTube and look those up, they're really pretty funny.
But so the concept here is that bystander CPR actually does matter.
It works.
And it doesn't work great. It works a little. And the reason it works is because it buys you an extra couple of minutes to get the defibrillator there, and that's sometimes critical. So without it, you only last 4 minutes. With it, you last 6 or 8 minutes. That's really terrific. There's really not much evidence that how you do the CPR matters. We have all these rules for it, but what really matters is you get a little bit of circulation. And the reason that having the dispatcher tell them just press is better than having the dispatcher tell them the other stuff, do both, is because they're more likely to do it. You're going to get some bystander CPR if you say you don't have to do mouth-to-mouth breathing, which most people don't want to do, and it's complicated. So keep it simple, get a little bit of compression, just keep them alive a little longer. That's why it doesn't work when we do it. It doesn't work when we do it because by the time they get to us and they've already failed their defibrillations, guess what? They're dead. What's the other song? Another one bites the dust. That's when you change to Another One Bites the Dust.
The other thing about this is, remember we were talking about trauma earlier, trauma which is more destination than time sensitive. Yes, we talk about the golden hour, but that's largely horseshit. So trauma, more destination sensitive. You want the trauma patient to the place with the resources to care for them, versus cardiac arrest, which is time sensitive. And because this adds another couple minutes by doing CPR, and for many cities, response times are not less than 4 minutes. So 4 minutes is when brain cells start to tank. If you get a little hands-only CPR by a bystander and you get 7 minutes, now you're coming into the arrival times of many EMS systems around the country. And that's why it matters.
38.
That was 38.
39, sorry.
39 is a pretty important paper, actually. So we all learned about how when someone has return of spontaneous circulation, ROSCE, after a cardiac arrest, that's a good start, but some of those patients do not have immediate return of neurologic function, RONFI. And so in the patient group that has ROSCE, but not RONFI, we had that paper in Australia and the other one in Austria, and we learned that cooling them down will improve their neurologic outcomes. And we were told, the song and dance, that the number needed to treat to get one good neurologic outcome was about 7. If that was true, and everyone wanted it to be true, that would be the best thing to happen to resuscitation in 100 years. I have to give Jerry some credit for saying, I don't really believe it, and he was being all grumpy about it. But in fact, here's this paper, better done, 950 patients, much more objective outcomes than the Aussie and the Austrian paper that compared 33 versus 36 degrees in this population and found, unfortunately, a lot of bupkis. It didn't really work that well. They didn't have the great they weren't able to repeat the great neurologic outcomes that they got in the first 2 trials, and it has a lot to do with how they measured the outcomes, which in this study was done much more objectively. And if you want to read more about this, then get Neil Little, who's faculty for this course. He wrote a really good editorial where he shot down the first 2 trials and identified all the problems that really didn't get enough airtime, that got buried under our optimism of hoping that we could actually improve neurologic outcome with the number needed to treat a 7.
I've made a lot of bets over the years for nickel about is this true or not, and I think I've won the vast majority of them, and it's really, really simple. Just bet no. When they say something is better than sliced bread, you probably not.
All right, we're there. It's 11:10. We're over.
No,
we have 5 more minutes.
5 more minutes.
5 more minutes.
5 more minutes.
All right.
I've actually talked about number 40 before, so let's move on to 41. Hospital variation in imaging, we talked about that a million times. There's a lot of variation.
Let's do 42 then.
42 basically brings up this idea that we do a lot of cosmetic blood pressure management rather than true end organ blood pressure management. So this is an opinion piece, sort of making recommendations on sequentially how to decide when to intervene with someone's blood pressure. But the bottom line is, if they're peeing and they're thinking, the odds are their blood pressure is adequate. And that to get it up to a certain map because there's a certain number that's thrown out there is actually, it doesn't make sense on an individual patient care basis. So this is bringing in the concept of permissive hypotension and not causing the harm that we can cause with some of the pressors and things that we add on just for cosmesis of a blood pressure.
And remember that despite the fact that people come down from your ICUs and they have very strong opinions about which pressure is indicated in which setting, and I can't believe you, intellectually bankrupt fool, you hung dopamine when surely you should have hung norepinephrine. Have you read nothing? Let's be clear. No pressor has been proven superior to any other pressor in any clinical situation. That's number one. And number two, no pressor has ever been proven to improve outcome in any disease.
Well, except for anaphylaxis.
Oh, thank you. I don't consider anaphylaxis a disease. It's an exposure.
Right. But that's a great point. So, we treat blood pressure, we're really treating ourselves, I think. Now, there's got to be some point where it's too low. We would like to get it up. But that unfortunately doesn't mean that getting it up with a pressor actually makes outcomes better. And there is no evidence of that. I've said this to ICU doctors many times, and I've said, just show me where's the evidence. So that doesn't mean it's not true. It doesn't mean that pressors are useless, but it means there's no evidence of utility, and they've certainly never. They don't want to go there. They don't want to. They don't want to study that. The idea of less is more is an important one. It's true, Diane said, for hypercapnia, where it's clearly important. For many things, don't give blood. One of the lectures talks about don't give blood to get it up to high, get it up to moderate. Well, is even moderate good? Maybe get it up to low is good. We don't know. For many of these, we don't know what the cutoff is. But we know that our natural instincts are overdue almost everything. So if you just back off somewhat for almost everything we do, same is true for blood pressure. It's really bad to have a blood pressure of 180. And it actually is one of the almost only things I know of where treating a number is actually useful. You get better outcomes if you don't leave them at 180. But you get a big bang for your buck if you go down to 160 systolic. From 160 to 140, there's almost no change, except for more side effects. 140 to 120, which is what all the guidelines tell you, it's not normal, you actually get no advantage, and you get harm. In most of medicine, we've set the aims much too high.
The same, as fast as we all try to go. Nosebleeds are the one thing that I'm not deficient on, because I let all of them wait at least 45 minutes, and when I go in, they're not bleeding, I don't do anything. Because the more you do with them, the come around, they bleed more. So I go in, they're not bleeding anymore. Bye-bye.
Love it. I love it.
43, I think, should have been a huge headline and scandal. It's the discrepancies between the date. When you post a prospective trial in the .gov arena and post this is our primary endpoint and this is our secondary endpoint, then that should be it, right? That's your study design. It's not fair to, after you get the data, change what your study is. But that's what this looks at. 110 trials, many were industry sponsored, and they compared what was posted in their .gov for what's our primary outcome, what's our secondary outcome, as opposed to what was the data in the peer review journals when the study was done. These authors were from OHSU, and they found all kinds of things. That new primary outcomes that were inconsistent with the posting were present in 15%, 1 in 7. They invented a new primary outcome. When they talked about what adverse drug reactions they were going to report, you can imagine it's an antibiotic drug-sponsored trial. You kind of want to play down the diarrhea and the barfing and the things that happen. So ADRs were discrepant in the published report 35% of the time. Other adverse events were much more reported in the .gov site, 33 out of 38, than in the manuscript. And so this really talks about the scandal of manipulation of what is posted at the .gov site as a really reasonable prospective trial with important primary outcomes and secondary outcomes to the crap that got published in the journal after the people massaged their data and decided what they're doing, even including 1 in 7 changing what the primary outcome is.
So let me just back up for a second to say why this is important. The notion is if I'm testing something, and I look for, not test one thing, but I test two things, I increase not a little bit, but geometrically the chance I'll find a positive outcome. So if I test 10 different outcomes, there's a 99% chance, if the same drug tests against itself for 10 different outcomes, mathematically there's a 99% chance that in one of the 10 outcomes, the drug will be at least twice as good as itself. Which means that I can shoot at the wall and say, I'm shooting over there, and I get over there. Instead of saying I missed the bullseye, I just go over there and redraw the bullseye. That's what changing the primary outcome is.
And I will have hit something because if I test a lot of things, something will look good. This is the concept of using chance and pretending I was actually looking for that when I was really looking for this. I only got that by chance. That's mathematics. Chance occurs all the time. And that's what this is about. That's why when somebody writes a paper which says, here's our primary outcome, another version of this is, we had a primary outcome, we had 4 co-primary outcomes.
Co-primary.
What does the word primary mean? I think that the Latin root is 1. There was only 1. You can't have 4 co-primary outcomes. It's a complete lie when you do this. And so this is, nowadays, since journals say we won't publish your work unless it was registered beforehand, you got to register it, which means I say, I'm shooting over there. I hit there, I just change it.
And the
what's
journals
amazing
let it
is
go.
the journals don't look.
So .gov holds their fire to the feet, and then the journals ignore it and publish it anyway.
And
And
now
one
we
of the
are
most
done.
notorious ones was recently the paper that said and you probably heard about it, you'll hear people quote it, that otitis media, despite the fact we have lots of papers that say the real treatment of otitis media for most patients is nothing, watchful waiting, this paper said, no, you can't give amoxicillin, you have to give augmentin. You have to, a regular antibiotic's not good enough, you need to use a bazooka for otitis media. And in
Sponsored
that
by
paper,
Augmentin, by the way.
right, and in that paper, they really downplayed the adverse drug reaction, and they had changed their primary outcomes. This was one of the papers that was
And
part
their
of the shame
secondary
here,
outcomes.
and it really proved that what that paper actually showed, the one that's the short story by the drug companies was Augmentin's better for otitis media. The real story was the cure for otitis media is diarrhea.
And it was in the New England Journal, and it sold $1 million of reprints.
We're over time, but I want you guys to look at number 47. If you want to give tetracaine to your corneal abrasion patients, have at it.
Good work.
Okay, really, truly grab that one. It doesn't hurt them. All that stuff's a big lie. It makes them feel better. It's just, they steal the bottle anyway.
So let them
have it.
So we have docs that say, "But I can't do it because I'll get in trouble. They'll write me up." And so we have residents who go, "Here's what's going to happen." They go, "Can I have more of those drops?" And the resident says, "These are the drops that I gave you that work
you
so
feel
well,
so much better?
and we're going to throw them out. I'm just going to leave them here on the table.
I'll
We'll
flick
be
it into
back
the
to
trash can."
discharge you in a moment." And some of them will even go so far as to say, "If I don't see the bottle, I'll assume the nurse threw it out."